Hey everybody, it's Dr. Eric Balcavage. We're back for another edition of the Thyroid Answers podcast. And today we have another guest. His name is Dr. Michael Biamonte. I think I got that right. He's a doctor of naturopathy and he's a clinical nutritionist. And he's in the state of New York. And we're going to talk about, maybe talk about candida. We'll talk about a little bit about thyroid physiology and talk about maybe his approach to addressing maybe both candida and thyroid issues. So Dr. Biamonte, welcome to the Thyroid Answers podcast.
Thank you, sir.
So maybe the first place to start is to get a little background on you. Who are you? Why should the listeners pay attention to what you have to say?
So I'm a naturopath. I graduated in the early 80s. And when I got out of school, my first real work that I did was at Grumman Aerospace. I found a bunch of aerospace physiologists who were developing a computer model of the body. Mm-hmm. And Grumman was doing this at the behest of NASA because they wanted a tool to be able to assess the astronauts' nutrition when they were in the space station and prolonged space missions. Because there's an issue with calcium loss and nitrogen balance and whatnot when you're in space. So we essentially developed a computer model of the body, which was table-driven, which means that we could insert different physiological steps when we found them rather than having to rewrite the whole program. And essentially what we did is we took Guyton's physiology book and Harper's biochemistry, and we loaded it into this computer in a sequential stepwise function. And then we took work from other doctors like Jim Seema and Ken Brockman, who were kind of barnstorming chiropractors who were using kinesiology to verify the use of the standard SMA 24 or 26, but looking at it from a more physiological viewpoint. Like, for instance, a BUN level, we would look at foremost as a anterior pituitary parameter rather than kidney, because the anterior pituitary controls hormones that signal the kidneys. The material that we had was getting, I would say we were getting a vast amount of material that we had to prove, and was becoming very expensive. So eventually they dropped the project, but they allowed us to keep all the data. So we then turned it into a tool that doctors could use in private practice. And we had many doctors who would send in their patients' lab tests to us, and we would print out a report for the doctor. The computer would only speak in physiology because we had people who were chiropractors and other people using it who weren't MDs. So we couldn't speak in pathology. We had to have the language be physiological language. This way they wouldn't be accused of practicing medicine without a license or some such thing. And we had quite a few people who were on this program, but we noticed there was something odd. There was about 30% of the people that were being serviced by this. And by the way, what the computer would do is look at your lab work and essentially tell you where your physiological or biochemical errors were, and then recommend diet and supplements to patch those up and put those back in. And we were having people get very good results with many illnesses, diabetes, arthritis, etc. But there was about 30% of the people who just were not responding correctly. In fact, they were having strange reactions. They would actually take the vitamins and have toxic reactions to the vitamins as opposed to a beneficial response. So I kind of volunteered to try to figure out what was wrong with these people. And I studied the lab work looking for common denominators. And I found that there was some type of dysbiosis. Now, in those days, we didn't even know what dysbiosis really was. But I found what I would call today a dysbiosis in all these people. And when we further researched, we found they had candida. I didn't really know what candida was, but I gradually learned about it. And I tried to send these people to their doctors to be treated for this, but they didn't really get a very good response from the doctors. Most of the doctors told them, well, everybody has candida or some such thing. They weren't differentiating between candida overgrowth and the fact that candida is a normal inhabitant of the intestinal tract. Eventually, I ended up sending a lot of these patients to Dr. Atkins because Atkins was prominent in New York, and he was one of the doctors who would treat candida. And they got a little bit of a better response, but still not that great. So I then took it upon myself to figure out how to unravel this whole mystery of what this candida was and how it was affecting people and what it was doing. And I came up with a system to eliminate candida, which I then turned into my book, The Candida Chronicles, which you can buy on Amazon. And the Candida Chronicles really explain my journey in discovering candida, discovering the tricks that it plays and how you unravel it and how you eventually get rid of it. For the listeners who are unfamiliar with this, candida is a yeast, but it's also a fungus. Actually, it's considered a dimorphic organism. It can live in two different states, and it will switch itself back and forth between being a fungus and yeast in order to protect itself and survive if it's exposed to any type of antifungal medications or poor environment. It can, when it overgrows in the body, it can produce many symptoms which are completely disrelated. As an example, somebody with chronic candida can have a chronic sinus problem, but they could also have a rash. They can have eczema from it. They could also develop asthma. As I was saying before, candida is a known trigger to Hashimoto's. So there are many different symptoms and conditions a person could have that's caused by candida that the person would never think. They would never put it or string it all together. And that's what some people have called candida the great mimicker, because it can mimic it mimics many other illnesses, but in actual fact, it's an underlying reason for a lot of illnesses that people would never think to put together.
So early on, you developed a software. Were you a naturopathic physician at the time that you were developing the software?
Yes, I was.
So how did you get involved with NASA hiring a naturopathic physician to develop a software program? How does that come about?
Well, when I was in school, my specialty type was really interpretation of blood work. And I was doing a lot of the research that it turned out I was reinventing the wheel, essentially. I was doing a lot of research into looking at a nutritional or physiological approach to looking at a standard blood test, like alkaline phosphatase, for instance. I don't look at alkaline phosphatase in the standard way a doctor would, looking at pathology. What alkaline phosphatase is a zinc activated enzyme. So alkaline phosphatase can give you an idea of your zinc status, but it's also heavily adrenal related. So when I look at alkaline phosphatase, I'm thinking adrenal and zinc in the person's case, rather than did they break a bone or something, some such thing.
I think that's pretty standard what we think about from a functional medicine perspective today.
Now
we
it
have
is.
We have a different way of looking at lab values from traditional medicine, and
yes,
and so
this was back in 1984 that we were looking at this. So that's quite a while. That's quite a while ago.
Okay. And so then you develop this software that then helps.
Well, let me go back a step. I was going around to different health food stores because I had just graduated. I was passing out my business cards, and I was telling the people what it was I was doing with this blood work research. And one woman told me, you need to speak to this Dr. Santoro because he's already doing what you're doing, and he already has a computer that's doing this. So I called this man up and I found out that he was the developer of the life support systems on the LEM, the lunar module, and he was a full-time employee at Grumman, and he was putting together this project. He was looking for nutritionists to come and join him as subcontractors, you would say, to help contribute to this computer model. That's how I got hooked up with these fellows.
Okay, got it. And today, gosh, just almost everybody's developing software to help analyze and make lab assessment easier for clinicians to kind of find the patterns of what might be going on in somebody's physiology. And I think that's great, but I also don't think I think there's also an art and a science to do. And so if somebody is relying on a software program, I think it's a good place to start, but I don't think as you get more time and more experience looking at hundreds and hundreds and hundreds of lab reports and dealing with people's signs and symptoms, we get really good at starting to interpret labs versus just read labs and say, oh, this is an adrenal, this is this, and start to look at it from a systems approach. Like, okay, we've got multiple systems impacted.
This is a key.
How does this one marker affect everything else?
This is key because these fellows I was working with were aerospace engineers, and aerospace physiologists. They were trained in the true systems analysis way. So the system that we were developing back then was based on subsystems. It had each section of the body in its own subsystem, and it used artificial intelligence and about probably 2,000 algorithms to do the study and the analysis. So that's a key, because many doctors don't look at things from a systems analysis viewpoint. They don't look at the body as one big system that has subsystems. They look at things in terms of symptoms as opposed to systems.
Right. And I think we're kind of starting to see that from a functional medicine perspective. I think those were the foundations of functional medicine, is to
That's
really
true.
take a look at the whole. The problem, I think, has become we have so many people coming from allopathic training into the functional medicine space that they're dragging the allopathic philosophy into functional medicine, and still using symptom treatment, but using supplements to treat symptoms or to try and manipulate labs versus what it should be is using the labs as an indicator,
Mhm.
and kind of a roadmap to what's potentially driving the physiology, and using diet and lifestyle and strategic
Like,
supplement
I think the
strategies to drive
problem
towards the
is
cause.
philosophy. When I was in naturopathic school, we were taught very strictly to think in terms of causes and to find causes. And I don't think still the modern medical model doesn't include that. The modern medical model goes more over symptom suppression using pharmaceuticals. In fact, as you probably know, there are many states in this country where it's illegal for you to say that you can cure a disease.
Mm-hmm.
So, yeah, I would agree with you. It's definitely a philosophical problem, and also one of orientation when you're being trained. So,
Sure. So you get into practice, you leave, you got your software, you're getting into practice, and then do you go into private practice and you're
mhm.
then
Yeah, I had
you're
5
making
offices at one time.
and then you're getting into more of a functional naturopathic medicine practice. When is it right off the bat that you decide, hey, this candida issue is potentially a bigger issue?
It's when we had a large enough populace of patients who were utilizing the system and plugged into it, and we started to qual why people weren't doing well, or those who weren't doing well, because they were sticking out like a sore thumb. It was about 30% of them, and they all had similar symptoms. They would take vitamins and have toxic reactions. The first thing you think of sometimes in that line is they don't have enough stomach acid, because people with hypochlorhydria, low stomach acid, are notorious for not being able to tolerate medications and supplements. But I found that was only one part of what was happening with them. There was this further dysbiosis that back in the early 1980s, nobody really had a full grip on. Luckily for me, I became friendly with the owners of a lab at that time, which was called the Great Smokies Lab. The lab later became Genova Labs, is how we know
Mhm.
them today. And Marty Lee and Steve Barrett became very friendly with me, and they were helping me to try to figure this out. And this is when the CDSA first came out, the Comprehensive Digestive Stool Analysis. So
Mhm.
they allowed me to run this test on my patients free multiple times in order to try to figure out what was happening. And I noticed there was peculiarities that in all these patients that were not tolerating the vitamins, they had a similar pattern in their stool. They showed signs of low stomach acid, low pancreatic enzymes. They had low butyrate levels. They had elevated fecal IgA or fecal IgE levels. They had an absence of friendly bacteria. That was the one thing that really hit me. Their lactobacillus and bifidus species were low, in some cases non-existent. So
So
in talking about all these parameters, they also tend to have a very alkaline pH. The pH of their stool was above 7.5, 7.6. So in talking to them about all these parameters, what we put together was that they probably had candida overgrowth, but the candida just wasn't showing on the stool sample because the culture wasn't showing it. And then we looked at um, how accurate the stool sample could be as far as the culture of candida as opposed to bacteria.
mhm.
And we found that because candida grew in the intestinal tract in a more spotty, blotchy type of formation, it doesn't grow in a uniform manner throughout the intestinal tract. It grows in spots and blotches that the stool samples probably weren't picking it up. So instead of relying on that, we took all these patients who had this basic profile I just gave you in the stool of these parameters, and we had them do blood tests for candida antibodies. And then a test came out in that era that was called the Candisphere, which not only looked at candida antibodies, but it also looked at the cytotoxic proteins that candida would release. And sure enough, about 100, I think it was almost 100% of all these patients that had that stool panel showed highly positive for candida in these blood tests.
So these are so somebody's testing, they're having IgG positive antibodies to either the candida or the candida toxins. Is that what you're saying?
Yes, that's
Okay.
what the Candisphere test. That's what the Candisphere test would tell you. It would tell you the antibody levels, but it would also measure the amount of cytotoxic proteins being released by candida. And these patients that had this pattern that I gave you before of the low butyrate, the high alkaline pH, the absence of friendly bacteria were all sky high on these tests. That's when we discovered that candida was the problem with these people.
And it could be those same things could be caused by other things, but you're saying there was when you did this antibody testing for candida and or the toxins, there was a high correlation between, hey, this pattern and these antibodies.
Very
So
high. Well, we now know that we
when
would call this dysbiosis today. Nowadays, we would call it dysbiosis because you're not going to find a candida patient necessarily who only has candida. It's very typical you find candida patients who also have different parasites. They could have H. pylori, they could have Klebsiella, Citrobacter. So that was the big standout back in those days. Now we can be more broader and a little bit more detailed in looking at it because now we know to look at it from a viewpoint of it's dysbiosis, and let's break down the biome and analyze the biome to find out exactly what that dysbiosis consists of. Is it more fungal? Is it bacterial? Is it parasitic?
Yeah, so I guess that somebody might say, well, if somebody's got chronic candidal overgrowth, is the chronic candida the cause of the person's dysfunction, or is the candida an opportunistic organism that's overgrowing due to terrain that's appropriate?
And that's where you have to do the research and do the testing, because candida could be an effect the person had of taking an antibiotic, or we all know that there are different medications that will cause candida as a side effect. So did the person get candida from that viewpoint of a medication, or was there some other trigger? Like very often we find people with low stomach acid will develop candida. People who acquire parasites will develop candida as a result of the dysbiosis they get. People with mercury toxicity develop candida quite easily. Anyone for any reason who develops intestinal permeability is going to develop candida. So yes, you're right. It has to be determined what the cause is.
So why would you say that though? That somebody with intestinal permeability is going to have candida overgrowth? What's the
Well,
mechanism that would draw it? Are you just saying it's common?
you're normally gonna find them together because whatever caused the intestinal permeability also would disturb, let's say, or destroy the person's normal flora that protects you against candida.
So if somebody has permeability issues, they probably have low short chain fatty acids. And if they have low short chain fatty acids, then the
Candida.
bacteria that typically make those short chain fatty acids is potentially absent or deficient. If they have permeability issues, they may have compromised biliary function. And if they have decreased bile flow into the small bowel,
Then we
then
have the
they've
same.
lost part of the
Right.
innate immune response at the top end of the
Exactly.
GI tract. And therefore, organisms coming from the oral cavity from food can then potentially overgrow.
Or the organisms that are already there will just overgrow because of the deficit of the bifidus strains and the lactobacillus strains. So we could come up with a list of all these possible issues that would then trigger it from this viewpoint.
Mm-hmm. Okay. And so at this stage for let's help the listener. I think we already kind of talked about this. Candida can be a commensal organism, or is it always considered problematic or pathogenic?
No, it can be commensal when it's at a very minor amount and it's in a minor role. It's commensal. It's when it overgrows that it becomes a pathogen. And that when it overgrows, it starts releasing a host of different toxins, mycotoxins, neurological toxins, and alcohols. There's a strain of candida from Japan that actually can make people legally intoxicated. It can produce that much alcohol. So it's when it overgrows in particular.
Yeah. And I think I think I've actually think it's an interesting thing to see, especially if I've seen this in clients and in people I know who I would suspect have yeast overgrowth, uh, and they will maybe they drink a beer or two, and before you know it, they seem like they're
Yeah, you nailed it.
sloppy drunk,
That's
and
exactly what you're looking at.
people are
And
like,
then
"Oh my God, how much did they drink?" I'm like, "Listen, I've been watching them. They only really had like one drink, but between the aldehydes that are being
they're
generated
right,
by the
right.
yeast and then the alcohol breaking down, we've got toxicity, and that's
And then
essentially what they're experiencing, right?
and then you also have to remember that the person with chronic candida develops various deficiencies that are going to further aggravate that. They'll become very deficient in vitamin B1. B1 is essential to being able to handle alcohol. They'll become deficient in zinc, which forms many of the enzymes that help break alcohol down. So you have that as another issue that's going to
You there?
be a candidate of someone who has chronic candida.
So I lost you there for a minute. So the last thing I heard you say was that people with candidal overgrowth, they can have a B1 deficiency or a zinc
And zinc, yeah.
deficiency.
Yeah.
And what was the next part you said there?
So this adds to their susceptibility or their intolerance to alcohol.
Hmm. And if there is, let's say, a yeast or candida overgrowth in the GI tract, um, there's other potential challenges that could happen. Do you also see that there's the potential for more oxalate absorption into the body proper, which then can trigger more symptomatology in people? Or do you not see that as a
Yes. No,
possibility?
that's absolutely true. As a matter of fact, there is a test which accurately can measure this. It's called an oats test. It's short for organic acid test. The organic acid test measures organic acids that are directly produced by candida and also measures oxalates. And there's a very strong correlation between people with high organic acids from candida and elevated oxalates. A very strong correlation.
So today, we've got more genetic panels that are being done
Mhm.
to assess the organisms in the GI tract versus maybe some of the CDSA that was done in the earlier days. Um, do you find that these types of stool assessments find candida?
No,
Okay, so
not
why?
not the way you would think.
So why
And
do you think that is?
I don't honestly don't know. The rule of thumb still holds true even in those tests that if the person's deficient in friendly flora, they're going to have elevated candida antibodies and they're going to have symptomatology of candida. But the new genetic tests don't show it the way I thought they would. And I don't have an answer for why that is.
So if you took somebody, so how if somebody thinks they have a candidal infection, right,
Mhm.
or a yeast infection, and candida, is it just affecting the gut or is it potentially affecting other tissues as well?
Well,
Maybe
can
oral.
the toxins that candida releases affect the person systemically?
Mhm.
Candida itself largely is an infection of the intestinal tract. It doesn't always go systemic. Well, technically, systemic candida is something which is fatal. And normally, a person who has systemic candida is in the hospital with end-stage AIDS or cancer. There's the nomenclature gets confused. Patients will confuse the fact that they have systemic symptoms of candida with the fact of having systemic candida. They'll go to their medical doctor and they say, I have systemic candida, I know it. And the doctor looks at them like they're crazy because you say systemic candida to most medical doctors, and he's thinking you should be in the hospital because you have AIDS. or you have cancer. So there's a confusion in terms. Candida can translocate. It can go to the lungs. It can go to the liver. It's been documented to invade different organs and glands, but that's an exception to the rule. Candida mostly is in the gut, and it's the toxins that it releases that go systemic, which then affect different areas of the body.
So there is a bit of literature out there that candida can be one of the prime drivers of joint arthritis. Have you seen that information?
Intestinal permeability. In those cases, just about all the patients have permeability.
Yeah, I would agree. I mean, for the most part, where the organisms um, get out of the GI tract into the body proper, and there is some literature and research to indicate that, hey, this could be an issue. I've had my own clients that had chronic arthritic pain and joint degeneration everywhere, and then you start to look at the signs and symptoms. You're like, this is probably more of a candida yeast issue. I know one of my clients was set to have bilateral knee replacement, and we discussed that with the surgeon, like, hey, this guy's got chronic candidal overgrowth that we're working on. This should be something you might want to take into consideration prior to surgery. And the surgeon was very, I think he was very willing to listen to that discussion, and then was very concerned about that going into surgery. So we did delay the surgical procedure for a period of time to really get that under control. So
that was a good move.
The surgeon was I think he was pretty happy that was brought out before he did the surgery, because his concern was, had we not done that and now we put this device into the system, if he's already got some candida that's impacting some of this arthritic, it's maybe at the root of some of this arthritic damage, and that's maybe why it was everywhere, every joint, it was degenerated, that, man, he might have a more significant biofilm issue and infection issue once those prostheses got in there.
And for listeners, a hint to this is, normally if a person has that type of condition, there'll be certain foods or drink that will flare it up. And very typically, the person will notice that foods high in sugar or foods high in yeast, which may cause an allergic reaction, will flare their condition up. This could be a tip-off to them that they are one of these people that may have RA due to candida or permeability. Foods will irritate it.
Yeah, so I want to get into all of that, but let's talk about testing today. If somebody's got signs and symptoms, and we kind of hinted to this, that you could have really almost anything. And I'll give you my take on it. I want to get your intake, but my thought process is that cells operate from really one of two primary modes. They're either in low stress manufacturing mode, where they want to bring a lot of nutrition into a cell to support the manufacturing process, the production of hormones, amino acids into peptides into proteins, and they want to make things. Or cells perceiving stress, threat, danger, and that could be toxins, organisms, hypoxia. It could be a number of factors that do that. And under those conditions, they're reducing normal physiology and shifting to more of what we call allostatic regulation. And lots of things can do it, but definitely candida could trigger that cell stress response. And as part of that, and how I see, especially thyroid physiology, that often what we see is the cell or tissue adaptation to the threat. There's a natural downregulation of T4 to T3 as a protective response. And those same PAMPs, what we call PAMPs, pathogen-associated molecular peptides, can be not only activating the immune system, but they can also be the thing that drives thyroiditis. How do you see potentially yeast, or maybe even other yeast and candida, their toxins, triggering immune inflammatory responses? Is it similar or is it different?
Yeah, no, I would agree with you 100%. I would say you're dead on. What I'll add to that is that we treat thousands of candida patients a year very successfully. And when we reach the point where we're ready to re-inoculate the friendly bacteria, get their probiotics back in. After that point, when they emerge as someone who now has their biome rebalanced, what shows up on their further lab work as the biggest screaming outpoints in their body are usually adrenal thyroid problems. Now, one can argue whether or not having candida that long affected their adrenal and their thyroid function adversely, or we can make all kinds of arguments as to what and how. But one thing I know is that it is, because that's the number one thing we end up having to focus on the recovered candida patient is their thyroid function.
So maybe I misunderstood you, but are you saying that they may not have had a thyroid condition until you fix the candida issue?
No. But what I'm saying is a thyroid condition follows or accompanies having chronic candida.
Oh, I wouldn't find that hard to believe at all.
And the reason why I say that is because, as I just said, when we handle the person and they're rehabilitated as far as their biome, one of the on their lab work, one of the things that you'll always find most off the skew is are the thyroid parameters. Very common, you'll find them with Hashimoto's. Very common to find them with very high reverse T3. You'll find them with high cortisol levels, high estrogen levels, and
but you're
cortisol
seeing
and
that
estrogen downregulate thyroid.
But you're seeing that as part of they're coming in with a candidal infection. They already have probably reduced T4 to T3 conversion.
Mm-hmm.
You're already seeing that pattern on your labs. They may actually be the person who's already being prescribed, and many times inappropriately being prescribed, thyroid replacement therapy, which I think for a lot of people actually exacerbates the problem.
Yeah.
So they're already there. I would guess that as you start to address the candidal overgrowth and the candidal problem, what you probably see, because this is what I see, is that if they're already on thyroid medication, these are also the same people that they can't find the mystical dose of thyroid hormone that works right.
That's right.
They've been to the traditional practitioner who only gives T4. They've gone to the integrative or functional space where they've gotten T4 and T3, and they've T3 only. And now people are throwing T2 into the system, and no magical mystical dose, they can't find it. And because it doesn't exist, because the thyroid physiology, in my opinion, wasn't broken to begin with, it was adapting to a chronic threat response. Yes, so as you're seeing the improvement, then you're probably seeing improvement of those abnormal patterns of decreased T4 to T3 conversion and elevations of reverse T3, right?
And there's further pattern that we see in these people. We do hair tissue mineral analysis on these people, and we do that from the time they walk in the door, and we do it intermittently throughout their treatment. And the pattern that these people tend to have is a very high copper to zinc ratio, and in many cases elevated mercury. Now we know that copper and zinc are part of the receptor sites for thyroid hormone. In fact, Guyton, and back in Guyton's physiology book, Guyton said, in some way we fully don't understand, calcium and potassium act as receptors for thyroid. Calcium downregulates the hormone, while potassium will make these receptor sites more sensitive. And there's a relationship between copper and calcium and zinc and potassium. You could say that calcium and copper downregulate and zinc and potassium upregulate. So these people, when walking in the door, already have these ratios noticeably skewed, very off. As they do the candida treatment, the ratios improve, but by the end of the candida treatment, they still have that inherent mineral ratio imbalance that's affecting their thyroid more at the receptor site level as opposed to the levels of the hormone in their blood. And that's we also find the pattern with other hormones. Cortisol elevated in these people, which downregulates thyroid. Estrogen elevated.
Hold on. So when you're talking about cortisol, are you talking about blood cortisol? Are you talking about blood salivary cortisol? Or are you talking about urinary metabolites?
It could be all. It could be all of them. I would just say that these people tend to be more cortisol dominant than not.
Yeah, I don't know if I see that pattern consistently, because if you have somebody who really has reduced conversion of T4 to T3, and especially if their lipids are elevated, if they have reduced T4 to T3, then they're going to have reduced adrenal T3 over time, uh, because the adrenal gland can make its own cholesterol. It has the ability to do that,
Absolutely.
but most of the cholesterol that is used to make cortisol and other sex hormones at the adrenal gland is driven not by the cholesterol that's generated within the adrenal tissue, but from what's brought from the bloodstream. So
Well,
HDL docks but for the HDL to dock and get the cholesterol in, you have to have sufficient T3 to do that,
Right.
and you need sufficient T3 to support adrenal function. So I see kind of an opposite pattern with people with chronic infections, chronic cell stress response, is that their acute levels of their cortisol levels go down in time, which is, I think, why people call it adrenal fatigue.
Right. Well, here's the point. This goes back to Hans Selye's work. I don't know if you're familiar with him.
I am.
Selye, okay, well then you know where I'm going with this. During a person's illness, they're going to go through different stages of stress, and you will find them at different points. We'll find them at a point where maybe their cortisol, their epinephrine will elevate in the first stages of stress, and then as they continue through those stages of stress, eventually those hormones crash because the adrenals can't keep up the production of those stress hormones. So we're going to find them at different stages.
Yeah. Well, I think that's important too, because sometimes when we take a look at somebody's blood cortisol, the blood cortisol looks fine. AM cortisol may look fine, but they may have elevated urine metabolites or high or low salivary, high or low urine metabolites. So,
do you use the Dutch test?
Yeah, I'd use the Dutch test. I look at blood. I look at the Dutch. I've looked at all of them, but I think those things have to be taken into context as to, all right, if I see this on a Dutch test, what does that mean? Do we throw this term adrenal fatigue around? The adrenal gland doesn't technically fatigue. There's a shift in physiology there. And that may be due to, and especially as I look at labs, if they've got a reduced T4 to T3 conversion in time, they're going to reduce their ability to generate cortisol. And my perception is that the whole adrenal gland is not fatiguing, but what happens is as cortisol production goes down due to this tissue hypothyroidism, probably catecholamine production is going up. And catecholamine is not using, we're not using the same kind of mechanism to do that in the backbone to these catecholamines is really the same base that we're using for a thyroid hormone. So it makes you start to wonder, if I'm in chronic stress, do I need that tyrosine to make thyroid hormone, which was only going to increase my metabolism, which the physiology is trying to downregulate?
Right.
Or do I adaptively shift tyrosine to support more catecholamine production to support blood glucose regulation and support this threat response? So I sometimes, when we look at those pathways of where micronutrients go, we have this naive concept sometimes that, oh, I'll give tyrosine because I have low production and my thyroid gland is going to take it and use it the way I wanted to make me feel good. But the cellular intelligence uses resources to what best supports the cell, the tissue, and what's going on.
At that time. At that time. That's what the trick is.
So anyway, let's keep on this theme here. How do we, if somebody believes they may have a candidal issue going on, what's the best way to assess it? There's Cyrex Labs. Dr. Bujdani he's got some testing out there that looks at some mycotoxins. He's got antibody testing for candida in his panels. There is urine mycotoxin testing out there. There's stool testing out there. So in your opinion, what's the best way to determine if somebody has candidal infection?
There isn't one way. It has to be from a combination of tests. Because of the problems I mentioned earlier, there needs to be a combination of tests. You need to look at antibodies. You need to look at the most reliable parameters I've seen are the antibodies and organic acid patterns. Then you could also look at the stool and see if you can document an absence of friendly bacteria and an excess of other possible pathogens that are there. That's going to be your best bet. You have to look at all of those tests, and then you have to look at the person's symptomatology and their history. Because looking at the history is fascinating. Because what you'll find, and I often tell patients, I want you to go home and get a piece of paper and draw a line, and consider that to be your timeline of your life. Here's birth, here's where you are now. I want you to go back to where your symptoms became noticeable to you. Mark that off, and then go earlier and see if you can find an area of time where these symptoms were first starting to develop, when perhaps they were occasional. Then go earlier and see if you can spot a time where you were taking a medication, you had an accident, you had some event that would have disturbed your flora, your intestinal flora, and see if you put all that together. And the things that people will come back with are unbelievable. Like, I've seen people come back and they'll show me, well, here's where I had this car accident. I was in the hospital. I was put on antibiotics. And it was after that point that my chronic whatever started.
Oh yeah, I mean, I'm hoping almost everybody in the functional medicine space is asking for patients to do a detailed health timeline. I think that helps us understand the story of how we got here. Too often, and say what you want about allopathic medicine, too often what's happening is we're treating the outcome and not really how we got here, right? So we're saying, oh, you have diabetes, so we're going to treat your diabetes. Okay, wait a second. How did we get blood glucose dysregulation in the first place? And let's go back and back. So I agree with that part of it.
And as you go
Health history
back and
takes
back,
time.
as you go back and back, you can sometimes then want to look at things that you might not have thought of. Like, we had a patient who moved to a new home. The house had well water, and it was after that point of moving into this house that they started to develop their illnesses. So we started to look at their levels of serum manganese, and we checked their hair levels for manganese, and we found that they were manganese toxic, which is not uncommon from well water. And this is what caused their dysregulation. So when you look at the timeline, it can often help you to focus in on testing that could give you more data.
Yeah, I agree. So from a patient's perspective, right? Is there, if they have other signs of fungal overgrowth that they can see, let's say they think they have some oral thrush, or they have nail fungus, or they have skin issues, or tinea infections, versicolor, jock itch, would those also be indications that, or clues to them that, hey, maybe I have some type of dysbiosis or fungal overgrowth internally as well?
Well, first of all, thrush has been very confused. When someone really has thrush, their mouth is very painful, their tongue is painful, it's painful to swallow. Many people confuse having a white coating in their mouth and tongue as a result of perhaps dysbiosis with actually having thrush.
Mhm.
Overall, your question is interesting because we're not supposed to think that if you have an external fungal infection, that would mean you would have an overgrowth in your gut. That's not the way I think a lot of us were taught, but it coincidentally turns out to be true. The patients who tend to have a lot of intestinal candida or intestinal dysbiosis are the ones that are more likely to have external or distal fungal infections, like on the nails, athlete's foot, or jock itch, all of these things. And vaginal infections definitely are right in there. In fact, the Merck manual, there was an edition of the Merck manual back in the 80s that said treating vaginal yeast infections locally was essentially a waste of time, that you had to treat the overgrowth of candida in the colon and in the intestinal tract.
Yeah. I wouldn't find that hard to believe. I mean, I think some of the early wisdom, grandma's wisdom, was probably justified in some of the early stuff that we learned. Some maybe not so accurate, but there's some early thought processes that we just, as antibiotics came out, we kind of, and other strategies came out, we just kind of ignored some of these ideas and concepts. But So if somebody gets assessment, gets assessment that shows that he may have a yeast or candidal infection, um, whether it's stool, antibodies, organic
Mhm.
acids. Now,
And
organic acids,
let's say their symptoms justify this also.
yeah.
Symptoms and
Um,
history.
and yeah, I think that's important. And I say this all the time on this podcast, and is that when we look at labs, we have to interpret them based on a client, right? Based on the rest of
Mhm.
the labs. Just because a lab value is out of the what somebody might say is an optimal range doesn't mean it's inappropriate, and doesn't mean necessarily something needs to get treated. It may just mean it's a shift in the one marker that we're looking at, and it could be an appropriate shift or a temporary shift. So
Mhm. That's
always
right.
taking into consideration signs and symptoms and the rest of
And the
of the
environment,
labs,
also
right?
the environment that they're exposed to.
So there are now we need to say, okay, we've got this going on. Now we have to consider, how do we go about treating? And you've been in this field a while. Um, Today there's probably 100 different anti-candidal products on the market.
Mhm.
Everybody's got their anti-candidal diet. I probably had 2 or 3 new patients this week that are just coming off their 60-day anti-candidal diet that they worked with, but symptoms haven't changed. So, what's the appropriate strategy for helping somebody who does have candidal infection, or we believe has a candidal infection, whether we can totally identify it in testing or not?
This is what I have found works. I'd spent 20 years doing this the wrong way. I spent 20 years listening to the supplement companies telling me to use their products, and it didn't work.
Mhm.
Finally, when I unraveled the whole mystery of this and I found out what worked and didn't work and why, I came up with certain axioms that can be applied to any candida program. The first axiom is that antifungals must be rotated. And the reason why is because candida will mutate and become genetically resistive to whatever the treatment is after 21 days. 21 days is the magic mark where candida begins to mutate. Candida consists of daughter cells and mother cells. It's the mother cells which will begin to genetically, we can say, switch and impart this data to the daughter cells, and this is what makes then the medication ineffective. So in my first step of treating the candida, we rotate the antifungals 4 days. Why we choose 4 days is 4 days is long enough to get an effect without getting close to that mark of being ineffective, and because many antifungal botanicals have a variety of effects, they're broad spectrum in many ways. If the more we switch them around, the more benefit we're getting. So that's the first rule, is that we have to rotate antifungals. Second rule is you don't worry about probiotics until you have effectively removed the candida. Now, the vitamin companies are very upset with me because I've been saying this quite loudly for many years. But probiotics don't work the way the vitamin company portrays when it comes to candida. They give you the impression that if you take the probiotic, it's going to knock the candida out and everybody's happy. This is not what happens. I've seen thousands of stool tests on patients. I've treated probably tens of thousands of candida cases, and I can tell you that taking probiotics as an initial treatment is a complete waste of time. I usually tell my patients, why don't you just take the bottle of probiotics, go to the toilet, and just pour it directly in the toilet. Don't bother consuming it, because that's the effect you're going to get. Probiotics are great at controlling candida once you have removed the candida. When you remove the candida, then the probiotic can reinoculate and it can protect you from the candida coming back. But initially, it is not an effective treatment at all. There are many mechanisms and reasons why. I'll keep this brief, but that's a major mistake that people make.
Okay.
Another
What's the
mistake
third?
that people make is taking too many vitamins and supplements when they have candida. There's a list, and you can find all this data in my book in detail. There's a list of supplements or nutrients which actually will make candida worse, and there's another list that will have an effect to neutralize the antifungals effect. Most antifungals are trying to create oxidative stress against the membrane of the candida. This is how they work. And we have found that antioxidants will reduce that effect and render the antifungal pretty much useless. Now, on the other hand, as far as the nutrients that make candida worse, how I discovered this was very interesting. I actually started studying the mechanism of action of different prescription antifungals.
Mm-hmm.
I looked at nystatin, and I saw that nystatin's principal mechanism is it blocks candida's ability to uptake iron. So when I thought of this, I said, well, if nystatin kills candida by starving it of iron, why would a candida patient want to take a supplement that has iron?
Agreed. Well, yeah. Well,
Then
I think
I
we
looked at
overdo iron supplements to
well,
begin with, right?
I also looked at ketoconazole, and ketoconazole's mechanism of action is it blocks the candida's uptake of vitamin D. So again, I asked myself the question, why would a candida patient then want to take vitamin D?
Yeah, and that's another one I think we overdo is taking way
Overdue.
too
Yeah,
much
well, it's
vitamin D.
become the fad. Every 10 years since I've been a nutritionist in 19, I finished school in 84. And since then, every 10 years, there's the fad. There's the 10-year fad of a different nutrient.
Mm-hmm.
We went through the vitamin E, we went through fish oil, we went through
Mm-hmm.
CoQ10, we went through magnesium. There's always a
Mm-hmm.
fad. But this is a key mistake a lot of patients make. And I've had so many patients tell me that when they stopped all their vitamins and they just concentrated on doing the candida treatment, they felt much better.
Yeah.
Another interesting point I'll tell you is that there was a time when candida patients came to us, we not only did the standard candida testing that you and I have discussed, but we would also test them for their basic nutrient profile. We did it in different ways. At one point, it was using blood work. At another point, it was using organic acid testing. But we did something that would establish a nutrient profile for these people. And one of the things you'll hear candida patients say when they're on the diet is they're afraid they're not taking their vitamins, they're not eating all the different foods they used to, so they're afraid of becoming deficient. Well, we actually found that while a patient is recovering from candida, their nutrient base levels actually rise higher than they were before they started. Now, we didn't give them a single nutrient, but they would come to us. We'd get a profile. We'd see what nutrients were high or low, imbalanced. Then at the end of the candida treatment, when we tested them again and hadn't given them one nutrient, all their nutrient levels were improved. So this is telling us that their absorption and utilization of these nutrients is greatly improved, even though they're not taking them because we're eliminating a barrier. And very often with thyroid, and thyroid is another example here, is sometimes we're so focused on what we have to give or raise rather than looking at what we have to remove that's going to unblock something from working.
Oh, I totally agree. I think my biggest gripe with my peers in the functional medicine space is that they look at what's going on with thyroid physiology as broken physiology. The body forgot how to convert T4 to T3. The immune system is out of control. But when we really look at the science of what we have so far in literature, if we think about what happens at the cell level from that cell danger response, that Robert Navio has done a great job of kind of pulling those hypotheses together. Thyroid hormone, downregulation of thyroid hormone, decreased conversion of T4 to T3 in cells under stress, plays a either direct or indirect role in every step of the cell danger response. And when we talk about Hashimoto's and thyroiditis, we're kind of learned that the antibodies are like little Pac-Men going into the thyroid gland and causing all this damage. And what the literature shows is that's really not the case. Thyroglobulin antibodies don't cause any damage. TPO antibodies cause very little damage. And what's often driving the thyroiditis is the thyroid cells themselves. And it's my belief that it's the PAMPs or DAMPs that are released due to these infections and tissue damage
Great,
that then
100%.
bind to the pattern recognition receptors on the thyroid cells themselves. And that initiates the thyroiditis directly. And now they release signaling molecules that bring the T lymphocytes in and causes the damage. And
this is what I've been saying for years, and people told me I was crazy.
No, I wrote a book about it. So the whole idea is that, and you've probably seen this, I see this all the time, that if that theory is correct, that's likely why when we address the chronic infections and deal with permeability issues and then start to support the recovery of tissues, that we don't need to give more thyroid hormone. We need to give less because they absorb more. The thyroiditis doesn't get worse, it gets better. And a thyroid gland can recover as long as we're not over medicating them. And as we continue to help support the decrease in the dose, the thyroid gland recovers. Why that's so important is if we're telling a person that they have an immune system that's lost control and it doesn't know their own thyroid gland anymore, that's a really negative way to think about the physiology. And now the person thinks their immune system is attacking them. And if you believe that's the case, you're screwed no matter what you do.
Yes.
But I've been doing this almost 30 years and viewing simple principles, what I believe are the functional medicine principles, and making sure that we have patients on the least amount of thyroid hormone possible as we start to work with them. They get not only do they not continue to create issues, but it makes it easier to treat them. And I totally agree with the vitamin D. I take most of my clients off in the vitamin D initially, if it makes sense, because I don't think we assess it right. I don't think we
it's
really know what's going on there.
What's interesting is D displaces magnesium. When we see people with elevated tissue magnesium, often they're on vitamin D, and that's because vitamin D causes an excess vitamin D. Let me just stand. Excess D causes an assimilation problem with magnesium and causes it to become biounavailable, so it piles up in your tissues.
Yeah, and there's a interesting paper that came out, and I don't know if you saw this. I think it was like 2 years ago where they did some studies on, you cannot do these studies in humans, but it would have been neat. But they took rats and knocked out the VDR receptors, and the rat could not get fat. So when you think about what's going on there and what happens with vitamin D, we say that, hey, people, the heavier they are, more vitamin D is getting stored in the fat tissue. It's not getting stored in the fat tissue. It's getting converted in there to help reduce the inflammatory response, make more space for more storage. And so more vitamin D may actually lead to more obesity in time. And I think we're doing a huge disservice to people. And we have this American philosophy that if some is good, more is better, right?
Well, they changed the reference ranges for vitamin D 20 years ago, I believe it was, and I'm not still sure what that was based on. Originally, the levels of vitamin D were based on clinical symptoms. If the person had rickets, mottling of the teeth, or something like this, so whatever level was preventing that is where they had the reference ranges set, pretty much. And then when all the research came out about some of the additional benefits of D that we didn't know, all of a sudden the reference range dramatically changed to the point where, unless you're taking a pill, you can't have a normal level of vitamin D.
Right. Yeah. I don't know if you've seen the work of Douglas Kell, but I think he does a fantastic job of kind of talking about the connection between infections, iron, vitamin D, and ties all those pieces together. I think he's done a fantastic job. And I think in an effort to try and manipulate a lab, right? We're doing quite a bit of disservice to a lot of our patients and clients. So
I agree.
It's sad.
There's another interesting aspect of candida and how it affects vitamin B12. For quite a while, we've seen patients with candida having very elevated levels of cobalt in their hair. Cobalt is the active sentry of vitamin B12, and we've seen people with high levels of serum B12, and these people were not taking B12, yet their levels were very high, and it was a bit of a mystery. And in the last few months, actually, I think it was a year ago, we started to get wind to what this was about. It's now been called a pyridoxal vitamin B12 deficiency. It appears that vitamin B2, riboflavin, is essential to activate B12. And if you do not have enough vitamin B2, B12 will not activate. So now, rather than looking at B12 as the problem, we come and we look at vitamin B2. So what could it be affecting vitamin B2 adversely to not be there to activate the B12? And we find out that how candida manipulates your physiology is one of the answers to this. A person could also have deficiencies of selenium, molybdenum, excess copper, and mercury, which could cause this problem with B2. But we also found that candida is a major monkey wrench in B2 metabolism, which then causes this abnormality with B12.
Well, yeah, I think you could try if you had a candidal infection, the other potential mechanism there is if you have a candidal infection, that's going to trigger to some degree that cell stress response. It's going to reduce the conversion of T4 to T3 potentially. And then if you have less available T3, you're not converting B2 into its activated form, because thyroid hormone is critical to the activation of B2 to its activated form. Now I don't have the activated form. I don't have methylated. I can't methylate my folate. Now I can't I can't go to that next step of the methionine cycle and cycle that piece. So this can get very deep and get very complicated as we start to take a look at all the potential mechanisms that go on there. But I think it's safe to say, and especially for the listener, that this can be a potential health issue. We've talked about a couple of different ways to assess it: stool, blood antibodies,
organic acids.
Organic acids. The challenge now let's come back to that for a second. When we look at organic acids, there are fungal and overgrowth markers on the organic acid test. Just because there's elevations of some of those markers, that doesn't mean that somebody has a candidal infection. Some of those markers could be elevated due to foods and other reasons, right?
But luckily the lab gives you that in the interpretation, so you can study that. You could equate that for yourself.
Yeah. So I see a lot of people that see that piece of it, but if you tie that piece, rule out that it's something else that's impacting it, and then potentially go over to the oxalate section on the organic acids, correlate that, then signs and symptoms. Then you're also going to look at
you're going to look at blood antibodies. You will want to assess your terrain, your microbiome, see what your friendly flora looks like, your commensal flora. You get all this data, you put it all together, and then you can also look at the person's response to treatment. Years ago, back when Dr. Truss wrote his book about Candida, it was really the first book ever written. The patient's response to treatment was a major indicator as to whether or not they had Candida based on if they had a Herxheimer reaction. So if you have, for those of you who don't know what this is, Dr. Herxheimer recognized that when he treated a patient for parasites or Lyme disease or some such thing, that they went through a period of feeling unwell, which was actually a physiological response to the dying of the microbe. When he would treat people with Lyme or whatever, as these organisms die and degrade in your system, they release toxins, and your toxic control system and your immune system reacts. So a person who has Candida, who takes a medication to kill the Candida, is likely to go through a period of time, which could be days, weeks, of feeling sick, feeling tired, lethargic, feeling like they have the flu. They could actually have all the symptoms of the flu. And this is called a die-off reaction. So if a person takes the medication and feels sick, it actually doesn't mean the medication's bad. It means that they are actually effectively killing the pathogen, and this is a sort of a side effect of the pathogen dying. Drinking tremendous amounts of water help relieve this, because it will flush the waste out of your body. Also doing something type of a colon cleanse, or taking a colon product that has binders in there also will help relieve the problem.
Yeah. So you talked before about using antifungals. You got to rotate them, and in your practice, you try and rotate them every 4 days.
We usually select four botanical antifungals for the person, and we do it based on lab work in terms of what sensitivity tests would tell us, and we have them rotate those.
So you're doing a sensitivity test. How are you determining the sensitivity test? If you're not, like, typically when people think about sensitivity testing, right, we're plating something and seeing it grow, and then we're putting something there. But if they're doing a stool test and they don't have any measurable,
that would be
right?
for the people who don't have any measurable. We do it based on their symptoms and what we know about the physiology or the mechanisms of the herb. For those who do have it, then we go by the sensitivity test. But we have them rotate the herbs while they're taking the binders. because these binders are very effective at keeping the dye off at a lower level because they're obviously binding the toxins before the person has a chance to fully absorb them. We like to use also enzymes to help physically digest the candida. There are different products out there that contain very specific enzymes that help digest candida. Diatomaceous earth is also a great thing to accompany those enzymes because the diatomaceous earth mechanically cuts right into the candida and other pathogens. And if those are taken with a source of fiber and then some type of as I was saying before, a binder, you can keep, not only can you mechanically help eliminate the candida, but you can also keep the die-off effects to a dull roar.
Is there, I mean, people have there's multiple anti-candidal products, but it sounds like what you're saying, some of these products have all of those, maybe a blend of a bunch of different things in them, but taking them consistently together over a 30-day or 60-day period of time, you're saying that
Get
the organism
mutation.
the organism's adapting to that.
Yeah, you're going to get mutation. There's a textbook on candida's adherence to the mucosal lining. That's by, I think it's B&C Press. I don't remember exactly, but this is covered really well in this textbook. The problem is that you need a combination of approaches when you get rid of candida. You have to have what I would call a mechanical approach, which is basically what I just outlined: enzymes, diatomaceous earth, binders, fiber that are going to mechanically help you eliminate candida. And then you need the pharmaceutical approach, which would be the botanicals. It has to be a combined approach, plus you have the diet, which is going to starve the candida. The whole point of the diet is to starve the candida and make it more amenable to eliminate it by not feeding it.
So there is, you'll see candidal diets all over the place, but what are your general philosophy about what a anti-candidal diet is?
Well, I've seen some of the wackiest diets out there being recommended for candida patients, but it really is a very simple thing. Candida thrives on sugar and glucose. So you want an effective candida diet is going to reduce your sugar and reduce your starch. And other than that, it becomes a matter of opinion because you'll get candida diets that will have no fish at all. Why don't they have any fish? Because fish have mercury. Mercury makes candida worse. Well, how do you know that the fish that person's going to eat is going to have mercury? You don't. That's getting a bit excessive. So then you'll get people who'll say, well, the candida diet has to be totally organic and non-GMO. Well, I live my life that way, organic and non-GMO, but for candida cells, I don't know that they're really watching you in the health food store saying, well, are you going to make sure you're buying this food that's non-GMO? I don't think they think that way. So we've got to stick to the basic principles. You want to lower your sugar, lower your starch. That's going to help starve the candida. When you see people get into like extremely wacky things, like they're from some other universe when it comes to these diets, I think in a lot of cases, that's what worked for the person for whatever reason. And this is a thing that happens throughout healthcare. Self-proclaimed health experts will find something that worked for them, and now therefore it has to work for everybody. It's got to be the truth for everybody.
You
And
must
that's
have
just
just
not
watched the
that's not
video.
what it is.
You
What's
must have
that?
just watched the video I did.
No, I'm sorry, I
I just
didn't.
did that. I just did that video
Well,
because
I've been
the 5 secrets of fixing thyroid physiology, right? This is the time of year where everybody's got their 5 secrets or 2 secrets
yeah,
or whatever. And there
yeah,
really are no secrets. There's foundational principles that are
right. There are
that
facts. Yeah.
we have to do. So I think that's good. So for the person, and this is going to differ, but what's a realistic time frame for somebody to expect clearance of a candidal infection? Because we have a
Probably
life
eight
cycle that
months.
you're talking about,
Eight
right?
eight months. 8 months has been our average. Most of our patients were able to clear the candida and get the biome back to normal. And when I say get rid of candida and get it back to normal and this and that, this is being verified by the lab tests. There are all kinds of multi-marketing companies out there that have candida products, and they say that my candida went away in 2 weeks, or it went away in a month, and all this. And this is all nonsense, because no one's testing these people and no one's following their progress after they write this testimonial. What I'm talking about is we can definitely show by lab work. The person walked in, he had candida. He did our program. Now the end result of the lab work is it's gone, and his normal flora is back. So that is an 8-month time span.
Okay. So can take 8 months. We talked about, and I'm sure the botanicals, there's a number of different botanicals. Are there any specific botanicals that you see being used on a consistent basis that you're like, that's not really very supportive of candida, and maybe the top 4 or 5 botanicals that you see most effective?
Some are a bit overrated. Pau d'Arco is a bit overrated as an antifungal, I feel. I don't use it that often because I don't feel like it's all that effective. It definitely is effective in a tea form. If you have thrush in your mouth, you'll see a reduction. But using it consistently, I've seen black walnut actually is more antifungal than Pau d'Arco is. There's a North American herb called lomatium, which was discovered by the American Indians. It's called wild black carrot root. And this I find to be very effective for the long haul. Another North American herb, spilanthes, also very effective as an antifungal. And there are different trademark products out there. Probably the best one is BioCybernetics. Just about everybody knows BioCybernetics. The original formula back in the 80s, back in the 90s rather, it was BioRadiance. BioRadiance was double or triple strength BioCybernetics, and since then they've cut that back a bit and changed the formula. It had a lot of bloodroot in it originally, and bloodroot is an herb that can cause fairly severe die-off. So they've toned it down, and that's very effective. Colorex is a very effective herb. Colorex is an herb from South America, which is a very effective antifungal. There literally are dozens of them. Even extracts of cinnamon. There is a new Japanese strain of candida called Candida auris, which is virtually not affected by any pharmaceutical. Pharmaceuticals have very little effect, but it's been found that when you combine cinnamon extract with the pharmaceutical, all of a sudden the pharmaceutical will work, and it becomes effective against Candida auris. Because Candida auris is a really scary strain of candida. It's devastating, and none of the drugs were working in Japan until someone got the idea of trying a host of botanicals in combination, and it turned out cinnamon had the highest inhibitory effect against it.
BioCybernetics has a combination of herbal products in it, right? So
yeah, it's a combination, but it still works. I have to go by what works. A lot of these combination products don't have enough in there to create an effect. They have so many different things at very low doses, and they don't create a substantial effect. So a product that has fewer things at a higher dose is more likely to have potency to create an effect. I know from trial and error that BioCybernetics is definitely very effective. It's also effective against a host of pathogens.
Mm-hmm. So if somebody was using BioCybernetics, and I use BioCybernetics in my practice, so
make sure you always take the patient always has to take biotonic with it. They don't always stress that, but BioCybernetics and biotonic are supposed to be taken together, because BioCybernetics is, if we're going to, from an herbology viewpoint, BioCybernetics is a very cold property herb, and it tends to dampen the digestive system because of its cold properties. And the biotonic is a warm property herb. It's meant to be taken with BioCybernetics to balance that.
And they also have a binder product that can go along with it.
GI detox.
So if you were going, but if you're rotating, this would be one of those things. So when you're talking about 4 different products, you would say, hey, you can use the BioCybernetics for 4 days, and then you would switch it to a different product.
Else. Right. Exactly.
And just rotate that through. So we talked about the average time. I want to cover the probiotics quickly, and then we'll kind of finish with, talking about how people can reach you. But you talked about how problematic probiotics can be at the onset. But at what point do you start to introduce a probiotic? Do you introduce a Saccharomyces boulardii? Are you looking at a stool assessment to look at what's there, what isn't there? Are you adding Saccharomyces boulardii as a general process you find that's not helpful? Like at what point and what types of probiotic do you find to be most effective? And then how long might somebody need to take those to continue to kind of crowd out the possibility of candida recurrence?
We put people through 2 rotations. The first rotation is of botanicals that work systemically, and they're generally on that rotation for 2 to 4 months, depending on the person and depending on their labs.
Mm-hmm.
Then they go through a second rotation of fatty acid-based antifungals, which are caprylic acid, undecylenic acid, and monolaurin, lauricylic acid, because they have a better ability to kill the candida deep in the intestinal mucosal. When those products are not demonstrating, this is the senior rule, when the person is not demonstrating any further Herxheim reaction from taking those products, so they've done the first rotation, Herxheimer reaction stops, then they go to the second rotation. They do that for perhaps 2 to 3 months until the Herxheimer reaction stops. And the Herxheimer reaction is different from the first rotation to the second. On the first rotation, the botanicals are killing the candida, we're going to say systemically, but keep in mind what we were discussing earlier. And then the second rotation, the antifungals are killing in the gut mucosal area. When that Herxheimer reaction stops, then we put the person on the probiotics. We have found that when the Herxheimer reaction stopping is from an empirical viewpoint and experience from studying the labs of those people, that is the time when the pathogens have dropped to the point where we can have some hope of reinoculation with the probiotics. And what I have found is that what's more important than the probiotic are the prebiotics. We use a list of prebiotics to help the environment. Most of the acidophilus products out there, or bifidus products, if they're human strain, or what's known in the industry as sticky strain, they're going to work if they have the right environment. What helps them, and what's more important than the product itself, as far as the probiotic, are the prebiotics. So for prebiotics, the intestinal tract has to be supplied with correct fibers for the friendly bacteria to then produce the short chain fatty acids. They basically feed on the fiber, and the end result is short chain fatty acids. We also give the new these new butyrine products that are out there. If anyone wants to take a butyrine product for any reason, it should have a TM next to it, which means trademark. That's the new age of the butyrine products. The old ones didn't work. The new ones do. We give them different substances, inulin, for instance, FOS. There are various substances which will help feed the friendly bacteria and make it grow, because this is very similar to gardening. Now, if you're gardening, you plant seeds. You don't plant the seeds every day. You plant the seeds and then you water them and you give them food. So once you establish those probiotics back on the person's system, you don't have to keep taking them every day. What's most important is to take the prebiotics to get them to grow. The thing, though, that hands down is the slammer that I had to confront was with bifidus bacteria. Back in the days when I was working with Marty Lee and Steve Barry at Great Smokies Labs, we gave people tons of very expensive bifidus supplements, and we never found the bifidus showing back up in the stool. It came to the point where we decided the only way to do this was to have them directly implant the bifidus. Because theoretically, if you're going to take the bifidus and it's got to go down in your mouth, down your throat, in your stomach, 40 feet of small intestine, then eventually make its way to your colon, that's not a very good prospect. So we decided the correct thing to do would be to implant the bifidus directly in the colon. So we had people using various bifidus products, putting it in an enema bag with a small amount of water and doing it like an implant. We would call it an implant, not an enema. Or we had people just take the capsule of bifidus and just insert it in their rectum and leave it there overnight. And we got far better results with having bifidus than reappearing on the test doing that than we ever did taking any oral bifidus product.
Yeah, I think there are some companies that actually have developed some technologies like
the bifidus suppository, you could call it.
Yeah, but the master supplements is one of them. They use a sodium alginate to protect the bacteria until it gets to the pH in the
Mm-hmm.
colon. Because a lot of you're exactly right. The whole job of stomach acid, bile, and enzymes is to not
Oh,
allow
yeah.
all these things to
Yeah.
get in. And that's why when somebody sees a product that says it's got 50 billion colonies, the reason there's 50 billion on there is because they know there's a small fraction, and
That are going
there's
to
a
make us.
rule, right?
Yeah.
The rule is that they have to have so much probiotic bacteria that this amount gets to the
Mm-hmm.
colon. I forget what that is. Like 10% of what's on the label has to
Right.
be guaranteed to hit the colon.
And that's why
And
then feeding and caring for the environment that 10% is going to arrive in becomes so important. Saccharomyces, to answer your question, would be a prebiotic. I put it in the category of a prebiotic.
okay, awesome. Well, we're up against time, so I think it was a good conversation to have. You said you have a book that's out, so tell people about the book, where they can get it, and where you're located, and if they want to learn more about what you do, where they can find you.
Well, the book is on Amazon like everything else is. The book is called Candida Chronicles. They can find it there quite easily. I have 3 different websites a person can look me up on. My base website is health-truth.com. I have 2 others, the New York City Candida Doctor and the New York City Thyroid Doctor. They can find me at any of those websites.
Okay. All right. So we will, I appreciate you coming on the podcast. I think we got a lot covered in gosh, it seems like a short period of time. It seems like we just got the conversation going, but an hour and a half is gone. So I'll let you go get back to your life. And I appreciate it. And maybe we'll have you back on the podcast at some time, and I'll get out there and check out your book and see what I can learn and like glean from what you're talking about in the book.
Right, I'm going to check out yours too.
Awesome.
Thank you.
All right, everybody. Thanks so much for listening to the Thyroid Answers podcast. If you enjoyed this, give us a review on Amazon or wherever you download your podcasts, and stay tuned for upcoming episodes. Thank you.